Okay, so I think we're live. Well, welcome everybody to I think the third SBI, so Society of Breast Imaging Summer Series. My name is Dr. Anjali Malik. I'm a breast imaging and intervention radiologist at Washington Radiology in DC. I'm also on the medical advisory committee for Bright Pink, a nonprofit that works to educate and empower young women on their breast cancer and ovarian cancer risk identification, stratification, management, and reduction. So today's topic is super important to me. We're going to be talking about breast cancer risk and how you can be reducing and modifying that risk through your lifestyle and behaviors. So tonight I have with me two great guests or fellow SBI members, if you guys want to introduce yourself. So Nina, I'll let you go first.
Okay, hi, I'm Dr. Nina Vinkoff. I am the chief of breast and Northwell Health, which is the largest health system in the New York area. And also within our Department of Radiology, I'm also the vice chair for patient experience for radiology. So always interested in sort of that overlap of where breast imaging and patient experience kind of come together.
Awesome.
Wonderful. Well, first off, hi guys. It's great
to
see
you. Hello.
And thanks for doing this. I've done it for the last couple of weeks. It's been a lot of fun. We want to welcome anybody who's tuning in for the first time. My name is Dr. Meredith Byers. I am the director of breast imaging for the community radiology side of Mallinckrodt Institute of Radiology at Washington University in St. Louis. And just like you, as we have reopened our centers and have started back to business, we have lots of questions. We have patients coming in with new concerns, and the discussion around risk reduction right now is especially important. So I'm happy to be part of it.
Absolutely. And if this is your first time, this is a new initiative for the Society of Breast Imaging for this summer, especially since some of us are in quarantine, some of us are in different stages of utilizing the Zoom platform. So this will be a weekly Monday evening chat series. We'll be discussing different breast imaging, breast cancer, breast health related topics. So tune in every Monday at 6 p.m. Eastern. So we can go ahead and get started. So everyone I think hears at least every October, breast cancer, 1 in 8 risk, 1 in 8 risk. So, we know that that's background, and to us, that means something to us. But Dr. Vinkoff, how do you explain to your patients what that 1 in 8 really translates to them?
Yeah, I think that number, although we hear it, still comes as a surprise to people. People say to me, that their average risk. And when you say them, well, average risk means you have a 1 in 8 chance, you have a 12% lifetime risk of developing breast cancer. Even though they've heard the number, I find still somehow so many women don't think that that really applies to them. And when I say, yes, average risk, that means 1 in 8. It still comes as a surprise to a lot of people. And they still will say the things that I'm sure you all hear people say, which is nobody in my family has breast cancer, I think it's really important. We can't say it enough that average risk is still a pretty high lifetime risk for developing breast cancer. And that's for all of us.
Absolutely. I mean, I equate it to if they told you that a plane had a 12% risk of crashing, you probably wouldn't get on it. You think something was wrong with the pilot. You'd ask, what can we do to change this situation? And so I'm not saying that this plane is going to crash, but it's the same concept that it's a high enough risk that we want to be managing it, learning what impacts our risk, and then again, how to reduce it. So that brings us to our risk factors. So the top two, of course, you referenced that people say they don't have any family history, but of course the top two risk factors are being female and aging. No amount of Botox is going to change that. And so what kind of conversations do you have with your patients about their non-modifiable risk factors?
Absolutely. I think that's a great question. And to go back to how you started this conversation, we talk about October being, we refer to it as Breast Health Awareness Month.
Sure.
Every month is Breast Health Awareness Month. We love the publicity in October, but we really want you to be thinking about it the other 11 months out of the year. And that's a message I'm constantly reinforcing to my patients. And I tell them, many of my patients are postmenopausal. Many of them have several friends who are female. And I say, when you and your friends sit around at lunch pre-COVID, when you and your friends are having a conversation, when you're doing your book club, are you looking at each other and saying, hey, did you go get your mammogram? Because you know, one of us is going to get it. When we look at our friends of groups of 8 or more, we know that somebody is just by percentage at risk to get it. So I really try to encourage my patients to, number one, recognize, as you said, the fact that we're female and we're all aging, which are both blessings. Those are great things to be doing. And to be means that breast cancer is part of our identity, part of our risk assessment. And we have to be aware of that every month is important to be getting our mammograms, and especially reminding your family, your friends, your colleagues that they are getting theirs as well. So that's kind of where I start the discussion with my patients.
That's great. And Dr. Vinkoff, you mentioned patients saying, I don't have a family history. And family history is something really important. It's something that I talk about a lot with my patients. I talk about it a lot with my Bright Pink community and followers and those I speak to. I'm sure you guys get a lot of the misconceptions, and two of the ones, well, you hit on one already about not having a family history doesn't mean you won't get it. Two other ones that I like to discuss are that your paternal and your maternal family history are important. Some misconceptions thinking that it only travels down our maternal side. And also patients not knowing their full family history. So breast cancer isn't the only thing that puts us at risk for breast cancer. So do you want to touch on that at all?
Yeah, I think we've come a long way. In the past couple of years in our practice, we're now doing risk assessment on every person who walks in the door. And so I actually think them answering the questions and then seeing, we actually are not just obtaining the information, but we're actually reporting it both on our reports and if people come out to be at increased risk directly to patients. And so now they're actually hearing what are all the things that are important to figuring out what that risk is, and then immediately hearing from us afterwards what that number is. And I think the conversations have changed since we started doing that. You know, we used to ask a lot of questions, but we didn't always ask all the right questions, and we didn't always ask the questions that would allow you to actually calculate people's risk and actually give them a lifetime percentage risk. And now that we're doing that, I feel like our patients have a different understanding for what all those different factors are that you just alluded to that go into determining what your lifetime risk is.
Yeah, no, that's awesome. And certainly, you know, at least it's a catch-all. It acts as a safety net, because so many patients will ask me, well, with whom am I supposed to have that conversation? Do I have it with you? Do I have it with my primary care physician? Do I have it with my OB-GYN? And the answer is one or all. Certainly be having the conversation. And I do think that in today's world, particularly with COVID, obviously, but even before that, it's always tricky for patients to navigate, you know, discussions like risk, genetics. We know there are so few genetic counselors per patient population, not just in the US, but in the world. Of course, COVID exacerbating those types of things. So really important for these conversations to be accessible at every level, and for us as radiologists to be facilitating them when and if we can. So we've talked about family history, and then the big two, age and gender. So of course we have race and ethnicity impacting our risk, and particularly an important topic always, but now with some of the current events highlighting some of the health disparities that we have. So Dr. Byers, could you touch on that?
Well, I think that's, you've all raised great points. Just to circle back on the last question, I think your point is exactly correct. Our patients are confused. They don't always know who they need to talk to about their risk factors, who they should bring it up with. And I'm sure you guys have had the same experience. I've had a patient say to me, you know, nobody's really talked to me about that. I'm really glad to hear it. And it made me think, I mean, it's a collaborative process. Me, your family physician, your gyn-onc, your breast cancer specialist, your surgeon, we're all part of that conversation around your risk factors. And I encourage our patients to solicit as many opinions as possible. We may not all give you the same information, but we all are working together in our patients' health. Regarding risk factors, especially for our patients of color, as you know, we as a breast imaging community have been dealing with this for a long time, although it does seem to be much more prolific on the national stage than it has been. But you and I know when we are going in to see a patient, we've looked at her imaging beforehand, we know how things look, and then we're met that she is a patient of color. We know that she's been perhaps doubly hurt in this scenario, right? Because our U.S. Preventative Services Task Force has not recommended her mammogram happening between ages 40 and 50, which it absolutely should, beginning at age 40, unless there is a breast cancer family history, and then beginning before, and happening annually in no uncertain terms, annual mammograms beginning at age 40 and continuing for your lifetime of good health. And then we know that their outcomes are poor and they are limited. And without becoming too political, it does speak to the fact that racism is a healthcare crisis, and it is in itself a pandemic. And we as breast imagers play a role in that, in making sure that our patients of color are seen, heard, addressed, treated, and evaluated with utmost urgency. So I really have tried to take it on myself to have a lens and looking at these patients and their lives and what they've heard and what's right for them, and trying to make sure that they are hearing very clearly, these are the recommendations for you. And please don't be dissuaded. Please don't be talked out of these recommendations.
Is that something that you tend to handle more on a case-by-case basis, or is there literature that you give to patients? What's your approach to making sure that you're educating both the individual and as a whole, the community that you're taking care of?
Well, I think that's a great question. And it's, there's not one right answer. So obviously, as I'm sure you guys do, a case-by-case basis, as I go in to see the patient, we're talking about it when I'm in there with them. I'm privileged to have a nurse navigator who follows up with my patients on a larger scale, and specifically with our high-risk patients, informing them because of your gender, because of your family history, because of your race, because of your breast density, which I'm sure we'll talk about, your risk is higher, and what can we be doing for you? And then talking with our physicians and referring providers. So we share literature with them. We make personal contact via a letter with our patients at increased risk, and then we have the one-on-one conversations with our patients. But we can always do more.
Yeah, no, absolutely. And a couple other points that I like to bring up when we're talking about women of color, and particularly, again, in this instance, we're talking about Black or African-American women. They, as you said, have worse outcomes, but that's independent of socioeconomic class. So they do present at more advanced stages with more aggressive cancers. They often have the triple negative type of cancer, which is more aggressive. Some of that, again, it might be biology that we've not yet studied, but there are certain exposures. We know, for example, the hair relaxers, the straighteners that they're using, that's something that does have some carcinogenic effects. And then for those that are affected by socioeconomics, access, sort of the culture, and the distrust of medicine, which we need to be working as providers to really be breaking down those barriers. And then, not feeling like they're heard. There are so many studies that show that patients of color, across both genders, feel like their concerns are not heard or dismissed. Anecdotally, I have a case where a patient presented with itching, and it went on to be Paget's, and it was really early on in my training. And we hear itching and you think like, oh, okay, rule out Paget's. And this was the patient's singular concern. She hadn't had a mammogram in a decade, but she had nipple itching, and that's what she wanted addressed. And it did go on to be Paget's. So just knowing that all symptoms need to be addressed, they are important to patients. And these are concerns that we need to be addressing. But it's not just for women of and then one more thing with that community is that they do have a high prevalence of the Brca gene mutations. And one thing I always like to bring up is it's one that's not tested for in these direct-to-consumer test kits. And so, the direct-to-consumer test kits might bill themselves as, we're super accessible with price, and, you can do this at home. And ironically or not, they do not address some of the populations that they might be targeting. So really important to be having risk discussions with your physician and having those, any necessary genetic workups. And
I think that's actually where we can play a really big role, because I think, it's really hard. I mean, your primary care doctor has so many things to cover and an increasingly short period of time that they get to be with you in the office. And so to really have a thorough conversation about what your risk is for breast cancer amongst all the other things that you might be at risk for can be difficult. And now we're recommending that that conversation happen by age 30. A lot of women are not even going to the doctor when they're age 30, or their primary care doctor is their OBGYN, and that's the only doctor that they're seeing, and they may not even be seeing them consistently. It's a lot to put on, especially I think on the OBGYN community, to say for these younger women to have a thorough conversation about risk during the short period of time that's been allotted. So I think that we can be the safety net in public health, in breast imaging, by getting the word out there, doing things like this and letting people know that it's important to ask, to have that conversation with your doctor if they don't bring it up with you, that by age 30, you should be having a conversation with your doctor about what your risk is.
Absolutely. I 100% agree. And I know we touched on women of color, but they aren't the only, when it comes to race and ethnicity, aren't the only ones at higher risk. So we know the Ashkenazi Jewish population does have a higher incidence of the BRCA gene mutations as well. And we also know that there are more than the BRCA gene mutations. So they are the ones that get the most attention. Of course, Angelina helped catapult those into mainstream. And that was kind of what I was referencing when I said women might only know their breast cancer family history. So Dr. Byers, you want to touch on cancer history as a whole and how it impacts breast cancer risk?
Sure, I'm happy to. I think first off, your point about our women ages 30 and above not knowing that this is the time to start having the breast history conversations and the breast health conversations is extremely important. I think we have to work as a team with our primary care providers, specifically with our OBGYNs, our family medicine or internal medicine doctors, to make sure that just as they would refer a patient to see a gastroenterologist for a GI complaint, they need to be referring these patients to see us for a breast complaint. And in your point about itching, that is a worthy complaint. And that is not one that we dismiss. That's one that we want to evaluate. And we want you to ask us to look at this patient and not say, oh, I think it's a topical reaction, or I think that perhaps a steroid cream is going to be sufficient in treating. No, we really want to see that patient and investigate the added layers of her history or his history that might be important to that evaluation. We have a lot of discussions over with Brca and the additional genetics. We do a thorough cancer screening because, and sometimes for these patients, it's the first time anybody's really asked, well, have you had a history of melanoma, of colon cancer, pancreatic cancer?
Right.
Let's talk about your grandparents, any breast or ovarian cancer in those. I often find with my patients in their parents or grandparents' age, the additional cancers, the melanomas, the pancreatics, et cetera, may not have been highlighted, but the discussion around breast and ovarian was. And so we try to elicit that history. Also, I'm finding that at least for us, we deal with a wide demographic. So I have women coming to see me in their 30s, but I have a very active population that are 80s to 100. Mm-hmm. We have to access them differently, right? Because they're very different types of patients. So for my elderly patients, my geriatric patients, it really requires a conversation to pull this information out about their cancer history and their family history, because they may not offer that spontaneously, and they may wait for their physician to ask that question, as opposed to my patients of a younger demographic who have been looking online, have been looking at the websites, have seen a social media post, and really came to us because of something outside of their primary care provider referring them. There was something else in terms of publicity or news media that got their attention and said that they needed to come in. And, you know, kudos to Angelina Jolie. I mean, for bringing a lens on this. I think that's the type of attention that we want to continue.
Is there a particular risk model calculator that you all are using in your offices? Or is that just a dangerous topic to even come near?
It's kind of which day of the week is it, right?
Yeah.
We've used a handful of them. We've used the NCI, Gale, Tyrer-Cuzick, and we actually have an internal risk assessment calculator that we've also used. Given that we cover a variety of different hospitals, it really depends on which hospital we're at. Do you guys have any preference on what you use or what you?
We're using the Tyrer-Cuzick so that we can get the breast, density in there, which is really important. And we're reporting it consistently on every single patient. So every single patient that comes in, and we don't have to ask them the same questions every year because we're able to show them what they said last year and just say, have there been any changes since last year? So it takes 10 minutes or so to get a thorough history the first year. And then we know what the breast density is from that mammogram. And then after that, we're able to have stuff. But we report it. We report the TC risk both on our report, and then if it comes out to greater than 20%, our nurse navigators actually report that directly to the patient when they give them the results of their mammogram.
And we are doing the same practice for most of our facilities. Maybe when we're ready to talk about breast density, we can each share how we're talking about breast density with our patients and what we're telling them, because I really feel like that's been an exciting development for our patients to have that piece of information.
Well, I think that's actually where I was going to segue to next. So good point. So of course, breast density, for those who, I think most are aware these days, but it's the proportion of fat to fibroglandular tissue within the breast. And probably 15 years ago, a woman who was diagnosed at stage 4 and was told, and it was within 6 months, I think, of a normal mammogram, was told that she had extremely dense breast tissue, and that's why it was difficult to detect her cancer. And through her efforts, majority of states now, but not all 50 and not all territories, are reporting breast density to our patients. So it's required by law for us as radiologists to tell our patients. And it's in 4 categories. So you've got fatty, scattered fibroglandular tissues, heterogeneously dense, and extremely dense, and that's a proportion. And it's the ones that are 50% and above that make the detection of breast cancer more challenging, but also increase our risk a small percentage. So it does have an impact on our risk, particularly in today's day and age, where some of the modifiable risk factors that we'll be talking about also have such a big impact on our breast cancer risk. So I guess I'll start since I'm talking now, but in our practice, of course, everyone gets the FDA mandated lay letter, which is the plain language letter that describes breast density. And we encourage specifically for those who are heterogeneously dense or extremely dense, if it's via screening, we discuss that they need to have that discussion with their doctor. I personally go the extra mile, if you will, and if I see that they have premenopausal breast cancer history or something else, will specifically put in there. So we don't do risk assessments through my practice. We have we have 7 practices across 3 states. And have a variety of community referring providers. And so which is a good discussion of, the difference between academic centers versus community. And so for us, I will specifically put in there risk assessment and high risk screening may be considered, and sort of to prompt that discussion. On the diagnostic level, if I have a person in my office, I'm also having those conversations face to face and putting them in my report. But it sounds like you guys have awesome, protocols set up for that.
I had to put myself on mute there for a second because I'm talking to you from New York City and you could hear all the sirens and everything in the back. Here in the New York area, we have a population that's been very educated about breast density for a very long time. So I've been practicing here for 20 years, and for the entire time that I've been here, a significant percentage of our patients were asking for mammography and ultrasound as screening together on the same day, and we're educated about breast density before we were even mandated to be informing people about breast density. New York was very early in the breast density legislation, and so we have had a statement in our lay letters informing people about their breast density. It does not recommend ultrasound, and we don't go so far as to recommend ultrasound in our reports, in our lay letters, or in our conversation with patients. But to be quite honest, in our area, we really don't need to say that. Everyone in New York knows that if your report says that you have dense breasts, that ultrasound is recommended, and that it's going to get paid for by your insurance. Thank you, Andrew Cuomo, for that and a million other things. So basically, about half our patients, actually, which is about, in case anybody watching this isn't aware, about half of you have dense breasts. And about half of our patients are having ultrasound on the same day as their mammogram. And it's by and large always the patients who have dense breasts. It's very unusual for us to see someone who has fatty breast tissue asking to also have the ultrasound on the same day as their mammogram, although we do see a little bit of that sometimes with high-risk patients. But I think we're lucky, we're in an area where people are really well educated about this topic, and where we've had a lot of governmental support to make sure that people are made aware and that it gets paid for.
And are you, do you have ABIS in your practice, or is this 2D handheld?
We did have ABIS for a little while. I think partially because we've been doing this for so long, we actually find that we do better having our ultrasound techs do it. So I was a big fan of ABIS. I liked the idea of it. But I've actually found in practice, our techs who've been doing this for a couple of decades now are very experienced doing screening ultrasound. And we were getting more consistent results having them do it. So we actually went back to handheld.
So in my practice, we actually do our own breast ultrasound, and it's still more worth it for us to do our own handheld as opposed to sitting through an ABIS reading and screening and then having to call the patient back. So our patients prefer that there's no callback from an ABIS. And yeah, the time it takes me to do a whole breast screening ultrasound is for me less than ABIS interpretation.
But I will say in ABIS's defense, if you're in a place where you don't have experienced radiologists or radiologists who have the time to do all those ultrasound exams, and you don't have experienced technologists, ABIS is a great way to bring ultrasound to patients in places like that, because it's, you know, ABIS can be performed by someone who's not a technologist. It can be performed by really a non-skilled person and get pretty consistent results after a period of training. And so you can bring the opportunity to have ultrasound to people who might otherwise not be able to have it. So still a fan of ABIS. It just, for our practice, it turned out not to be the right solution for us, but definitely still a fan of the idea of it.
Sure.
And we have, similar to you guys, we use the handheld ultrasound for screening. We're not using automated. We trialed it, but found, just as you did, that with really awesome technologists, and to be honest, sorry, that's my other child right there. He wants to say hi. Our technologists really make the difference, and if we can, if our patients are in good hands of our technologists, then it works better than doing the automated. To bring the conversation back to the discussion of density, we actually instituted automated density assessment. So we use a computer program that assesses density. Hold on, I'm sorry. Newt, come here, sweetie. But what we've learned is that maybe our subjective assessments of density have not been as correct as we thought they were. And that's been a real realization for our group, and using the automated system has added a level of conversation for my patients who said, last year you said I was dense, and this year you say I'm scattered fibroglandular. What does that mean? So it's in some ways has added an extra level of conversation with our patients about breast density and what it means.
Yeah, and that's a great point. It varies from practice to practice and what their comfort level is in using that kind of software, but an important option and tool for patients. So just to round out the non-modifiables, we talked about age and gender being the top two. We talked about our family history and the important things to know with our family history. Of course, genetic mutations, race and ethnicity, breast density, and then, of course, hormones are the central issue when it comes to breast cancer. So age of menses and age of menopause. And on that note, just talking about why hormones are so important when it comes to breast cancer. So, you know, we know as breast radiologists that they are estrogen and progesterone sensitive, or majority of them are. So what kind of conversations do you have surrounding hormones with your patients, Dr. Vinca? Oh, you're muted, I think. Yeah.
You know, the actual conversation around hormones tends not to be a conversation that I have that often with our patients are not taking hormone replacement anymore. Like, this was a conversation that maybe we were having 10 years ago, but I don't find that this is a conversation that we're having. We do have conversations with patients around, like I said, since we're doing a full-on risk assessment for everyone, we are asking people about things like, you know, when their first menstrual period was, and their lactational history and their pregnancy history and that kind of thing. But I will say we're not having, at least in our practice, we're not having specific conversations with patients about hormones. I don't know about the rest of you.
So we actually do have a population in DC that is on hormones, and we have a population of physicians, whether they're primary or OB-GYN, who strongly believe that, you know, whether it's for osteoporosis, heart health, et cetera, that it's part of their patient's regimen. It is something that I defer to if my patient is on hormone replacement therapy and they ask me about it and they say, do you think I should be on it? I say, everything has a risk and benefit. And we know that there is a small but definite risk from hormone replacement therapy. And it depends on what the reasons are that you've been placed on it as to whether, you know, it's the right decision for you. So, but I have practiced in other places where it was less of a discussion.
Yeah, in this area, it just does not tend to be something that we run into a lot, quite frankly.
Right. And the same for oral contraceptives. I think at some point there was more of a push in the breast community that it increased the risk for breast cancer, but because it decreases the risk for ovarian cancer, I think that's sort of fallen to the wayside in terms of those discussions. Do you have those discussions?
About oral contraceptives, not so much about breast cancer, like you said, more about things like, gynecologic cancers, not so much about breast cancer.
Right. So then, and again, just to touch on why that's important for breast cancer, it's because those cancers do have estrogen and progesterone receptors. That's why things like age of first menses, age of menopause, any hormone replacement therapies, they can amplify the effects and cause or increase the growth of breast cancer, which is how our modifiable risk factors come into play. And of course, we're in a huge lifestyle medicine and lifestyle modification movement, and things like COVID highlight reasons that we need to be reducing our comorbidities. So alcohol and obesity are the two big things that I tell my patients. So maintain a healthy weight and reduce your alcohol consumption. What are your big take-home messages for modifiable risk factors?
I think we're on the same page as you. I really try to break it down with my patients to talk about what they can be doing. Mm-hmm. I find sometimes when we talk about obesity or exercise, people think it's an all or none. Right. You have to be going to the gym or going on a run or getting my heart rate up this amount of minutes per day. And if I can't do that, then why do I do it? And we really talk about it as a lifestyle. Taking a walk every evening with your family is a great idea. Getting outside on the weekends to do something outside of the house. Right now, as we were all quarantined for so long, if you had a treadmill, if you had weights in the house, if you had something you could do, if you had a YouTube channel that you like that you could go to and watch an aerobic video and work out or do a yoga or do Pilates, just what is a small thing you can do to get you to 20, 30, maybe 40 minutes of exercise a few days a week and then increase from there. So I find that we have to be conscientious of how we're introducing the idea of lifestyle modification to our patients. It's not hard. It's if you could do one more thing this week than last week, and if you can keep that up, that's a lifestyle change. And in some ways, at least for my family personally, the fact that we were at home meant that we had to find new ways to exercise. And so just trying to, as these patients are coming back for their screening mammograms and their diagnostics, as they're ready to come back into our hospitals and imaging centers, having that conversation about what were you able to do while you were at home, and did you find anything you liked, and how can we build on that? That's a good way to introduce the conversation without it being too scary or overwhelming.
I think that's absolutely right, and I think that the really important point is that all the things you're talking about are not just good for breast health; they're just good for your health in general. Which actually kind of brings me to a somewhat related topic, and I'm just curious what the two of you think about this is. What's our role in breast imaging to perform more of a public health role in terms of other things that women might be at risk of? I know there's a lot of interest right now in taking the opportunity that we have for patients that are already coming in and having their annual mammogram to try to inform patients who might be at risk for lung cancer about lung cancer screening. Should we be telling the patients who have coronary artery calcifications on their mammogram that they might be, at risk for cardiovascular disease? We see patients once a year. Should we take the opportunity to remind them that they should be having their colonoscopy if they're the right age? Because the same recommendations are going to make you have decreased risk for breast cancer. And because we're seeing patients annually and playing a part in their annual care, in what ways can we be there for public health for women outside of just protecting them against, having a breast cancer diagnosed later?
I think that's a great point. I will say I definitely share and spread those messages on social media, but probably am guilty of not doing enough of that in the office setting. But I 100% agree that we capture patients sometimes more often than their own physicians do, and that it is a real opportunity to be having those conversations. So, good job on getting your mammogram, but have you also
this is what I'm thinking. Right, exactly. Easy stuff. Like by coming here and having your mammogram, every year, you've decreased your chances of dying of breast cancer by 40%. But did you know that you could, if you are a smoker or a former smoker, there's also screening tests that you can do to find your lung cancer before it kills you. Are you doing what you need to do to find your colon cancer? I think we could play a role in there. I'm really interested in seeing us play a role in there because like sort of what I was talking about before, everybody's so stretched right now in medicine. It is so hard for people to find time in the typical office visit to cover all the things they want to cover, that as many of us that can form a safety net for patients, the better, I think.
Yeah, I will say I use some of those whole breast screening ultrasound minutes to have lifestyle conversations. One that's really important to me, I'm a plant-based physician, and so I do talk about diet quite a bit. I know that nutrition studies are limited and no one silver bullet diet has been established, but we do know that there are some things that patients can be doing to optimize their health. So, eating fiber, not just good for the colon, good for everything, and it has been shown even in breast cancer. One hot topic, soy, we can maybe hit on that, soy consumption, and then the processed meat. So I'm plant-based, that's an easy no-go for me, but studies have shown that it's probably a no-go for everyone. So do you have any kind of diet-centered conversations with your patients? Or what do you do when you're approached with that question?
Sure, and I'm approached more often than not, which just shows the increased education and awareness of our patients, which is great. Mm-hmm. Going back to Nina's point about recommending other screenings when our patients are coming in for their mammograms. In our center, and maybe yours is the same, we have many self-referred patients. So they're coming to us without a physician navigating their care. They've chosen to get their mammograms, which is great. But then we really are the safety net, right? Because they may not see anyone else. So I think that I refer to mammography as the bread and milk of our hospital grocery store, right? It's what gets patients in the door. Right. We'd like to tell them, hey, while you're here, we also have bone densitometry. We have lung cancer screening. We have a chest X-ray if you haven't had a chest X-ray in a while. We have lab services. We have cardiology. We have multiple other facets. And often as you are the one listening to them and hearing what's going on in their lives, you pick up on clues that maybe this would be a good choice for you. Perhaps they're here because they have a loved one hospitalized now. Maybe they have a spouse who is diagnosed with lung cancer. That's a key to me that we need to talk about lung cancer screening for you as well. There's a strong chance there's an environmental risk for you. Just those kinds of clues that our patients give us that say we could just be one more layer of education for them. And I have to agree, I'm like you in that I probably do more on social media around it than I do one-on-one. Yeah, that's a lesson to take home, that I could be doing it in person and not just online. Then to your second question, so I'm in St. Louis, which is, I consider sort of the heart of the Midwest. Right. And meat consumption is exceptionally high here. So it's a big jump to talk about breaking up with meat. And it's something that we've done as a family, so I can speak to it personally on what worked for us. But it goes back to the same thing I was talking about, exercise and lifestyle. You got to break at it. You got to take it at pieces. You've got to decrease it, not stop at cold turkey. And that's really where I start that conversation. We try to also take notes as we see patients each year. If we had a conversation with them one year, that we keep it as a record. So we see them next year, we can ask about it. Hey, you and I talked about this last time. Are you having any luck with that? What did you find out? What's working for you? So just one more way to connect with the patient. I'd love to hear what you guys have to say about soy. That's not as big a conversation around here as the meat consumption is.
Soy is a big conversation around here.
Sure.
I sometimes notice that there's been a change on people's mammograms, and I will actually I will specifically ask them about soy, and soy is very often the answer.
Yeah. I mean, I on my social media do interact with a lot of plant-based physicians. So that just tends to be part of the conversation that I have both on and offline. And I do have a lot of patients that are interested in it. But on the flip side, I will have patients who develop breast cancer and who say that I'm plant-based and I exercise and I do all the right things, which is absolutely true, which just goes to show, sort of as a throwback to how we started, that 1 in 8, that 12% is so high, and that, we can do all the right things on the modifiable side, but we have enough things on the non-modifiable side, which is why these are so important. I grew up in a small town in Tennessee, so I'm familiar with the meat and potatoes diet, or just the meat and meat diet. So yeah, I do think that at least having that conversation about the processed meats, or maybe having the, know the source, organic type discussions, of course, that, limits your accessibilities, and being mindful of that. But I think it all comes as a full package. And I agree with you that, just chip away slowly, both systemically and then on the individual level. I don't think 5 or even 10 years, certainly not 10 years ago, but even 5 years ago, I don't think the word plant-based or the term plant-based was tossed around as casually as it is now, which just goes to show that we've had, a societal and cultural movement, and that we could totally change the dial on health as we know it. So, we've sort of hit on some of the causes. You mentioned environmental when it comes to lung. There are some environmental things, kind of how I referenced the cosmetics, when it comes to breast as well. But let's talk about some good things. So there are some things that do reduce our risk for the development of breast cancer. So breastfeeding. I know you were both mothers, so I've not yet had the joy of attempting or successfully completing breastfeeding. But what do you talk to your young mothers or women who have breastfed? What conversations are you having there?
I think we just started at the point of we encourage breastfeeding. Again, as you reference, as you go through the motherhood experience, you sometimes learn, even if you really want to breastfeed, that's not an option for you, or it doesn't work for you. And for me, with 3 kids, I had very different breastfeeding experiences with each of them. So there's no guilt, there's no shame, there is no pressure. But if you're able to do it, then it's a wonderful thing to do. Again, I know that especially our young moms, it's hard, right? So just being able to both encourage them without having them feel any guilt about their personal decisions is where I try to land.
Yeah,
I absolutely agree. I'm sorry.
No, yeah, no, I just was going to say, yeah, no, fed is best. I kind of use it as like that gold star that if you are up in the middle of the night for a 2 a.m. feed or the twilight feed, and you're like, why am I doing this? A, know that, if you're able to, it's great for baby, but B, it's good for you. For breast cancer risk. So that's just sort of my motivating conversation on that end, that you do you and do what works. But if you're ever questioning it, know that at least 6 months can reduce your risk. So
it does make me wonder whether there might be an opportunity for outreach here. Like, I wonder, I'm always thinking about ways that we can get in front of people. Like, does anybody ever talk, especially now that we're really encouraging people to find out about their risk by age 30, is there an opportunity for us to be actually addressing women at the time of labor and delivery about benefit of breastfeeding, or plus minus breastfeeding? Maybe breastfeeding for a variety of reasons might be not something that you can do, but you might already be at the age, if you're not ready for mammography, you're very likely are at the age or close to the age where you should be thinking about what your risk factors are. And do we have an opportunity there at the time of labor and delivery to be having our first outreach? Should we be placing information about mammography and about breast health in the hands of obstetricians so that they can hand that information over to patients at the time of delivery? This is actually just occurring to me while I'm sitting here. I've got a whole new project to do after we hang up the phone. But
yeah.
Yeah.
I think the thing is that the age of motherhood is shifting. Of course, you know, I feel like I so rarely see new moms in their 20s at this point. It really is shifting to the 30s, which is another risk factor that we didn't talk about. And it is a touchy one because marriage and family planning are not quite as accessible as they might once have been, especially for the working woman. So just a variety of societal factors that are impacting that. But our age of first pregnancy does impact our risk, whether it's before or after 30. But you're absolutely right that the OBs, you know, could be, even in that scenario, the ones that are helping us reach that patient population. It is part of why I do the work that I do with Bright Pink, because, and I know that you two will be able to echo these, you know, these anecdotes that I see women who are pregnant and get their new breast cancer BRCA diagnosis, and their family history screams BRCA to me. You know, and instead it's the lump that they feel when they're pregnant, or you know, similar, they haven't had the opportunity to family plan. And they go on to find that they have a breast cancer and a BRCA. And luckily we have oncofertility in this day and age, but these conversations need to be happening, you know, for young women. We need to stop like compartmentalizing breast cancer as something only for the 30s and 40s. Conversations, it really needs to be happening in that initial gynecology visit, and that in those 20s visits, especially since cervical cancer screening has been spaced out the way that it has. That's really it is impacting. I mean, the gynecology community, I'm sure you've heard the same concerns, that they're not seeing women for their well women anymore. People think, oh, I only need to go in for a pap smear, and if not that, then I don't need to go in, which we all know is not the case. But
and they might not have an internist, so that might be it. I mean, there can be years there for these women in their 20s and early 30s where they're seeing a gynecologist intermittently for a pap smear and nobody else. It's no wonder that there's not enough education out there about some of these issues.
Well, and to speak to our gynecology colleagues who we know are stretched thin, right? Whose their abilities to see and connect with their patients are limited as well. The thing to circle back to where we started this conversation, I'm talking about breastfeeding and how we should encourage our patients and educate them that this is why it's a good idea. And also, to me, you know, your idea that kind of goes hand in hand with discussing pregnancy-associated breast cancer and the risk of that and how to address that. I mean, we all have the anecdotes of how many women have come to see us that are either pregnant, have delivered, or are breastfeeding, and they don't have this information. They talked about it to one healthcare provider, but didn't get to us until, you know, 2 or 3 conversations later. I feel like I spend a lot of time telling my patients in their 20s and 30s, if you have a breast concern, I strongly encourage you to ask to come see me, to ask to get to our breast imaging facility, to let us evaluate you, because they don't know that's a need, that's indicated. So it's about working with our gynecologist, recognizing the limitations of what they can do, but being just an open door for their patients. And so when they call me and say, I just saw so-and-so in the office and I'm worried about something, yes, they need to come over today. We need to see them right away. Let's not lose track with them. So it's a public service announcement. It's a conversation with our gynecologists. It's a constant conversation with our patients. We have to address it on all of those fronts.
I agree. But I also think it's really important when we start talking about modifiable and non-modifiable risk factors that we're careful not to put too much guilt on women about having the later pregnancy, not being able to breastfeed. I don't know about the rest of you, but one of the first things that a lot of women say to me after I tell them they have breast cancer is, what did I do? You know, women are already carrying around so much guilt and feeling of responsibility for the health of themselves, for the health of their family. And it makes me a little bit nervous when we have these kinds of conversations that women are going to feel like they have more control over whether they're going to develop breast cancer than they actually have. You know, still in this case, this is something that's going to affect 1 in 8 women. And I would hate for women to walk away from this conversation thinking that, you know, if only they had eaten better, if only they had dieted more, if only they had had the pregnancy at this time instead of that time, or breastfed for longer, that somehow they could have stopped themselves from having breast cancer. I think you try to do all the things that you can do. You modify all the things that you can modify. There's the genetic hand that you were dealt. There's all kinds of other factors that you were dealt that you don't have any control over. But in the end, it's hard enough to have breast cancer without having breast cancer and feeling guilty about having breast cancer. And I hate it when I see that. Like that's just heartbreaking for me when I see that.
I 100% agree with that. And it's one of the reasons that I talk about risk so much. Yes, because I work with Bright Pink, but also because we are already dealing with so many risk factors that we cannot control. So it's just a way, when you talk about modifiable risk factors, of bringing women in on, playing an active role. There's so much, whether you call it breast cancer awareness or breast health awareness, there's so much of the pink and the awareness. And to me, it really translates into anxiety. And it's not a lot of action. And so it's why I like to shift the conversation to things that they can take control of, not because I expect it to, eliminate, and nor do I want them to think that it eliminates risk, but just because if they're playing an active role, it means they are getting that screening, they are having the important conversations, and they are maybe finding a genetic mutation that means that they have the early screening and find it, or, have the preventative mastectomy and go that way. And that's really what all of this is about. I mean, I think we would all love to prevent cancers, but we're probably not there yet. And so really it's just about everyone taking an active role.
Absolutely.
And I think to go back to telling our patients, giving our patients suggestions for what they can do, what they can control, what's in their control. What's in your control, number one, is getting a screening mammogram annually. Right. And I think that sometimes our patients have the misconception that if I have a mammogram, I've prevented my breast cancer. Somehow it wards it off. It's a protective effect. Right. And we know that's not true. What we've done is give us the opportunity to catch it at its earliest possible stage. And so by having your screening mammogram annually, you have said, if there is something wrong, I want to find it as soon as possible for treatment to be as effective as possible, to give myself the best result possible. And so when I counsel my patients on risk reduction, I do come back to that. That's one more tool you have in your arsenal of something you can do once a year that's really helping take care of you and increase your longevity and decrease your overall risk of succumbing to breast cancer.
We should probably talk a little bit about the other screening tests that you can do if you're in a high risk category, because we didn't really touch on that. That's a great idea.
So we did mention ultrasound as it relates to breast density, but it also does catch 3 per 1,000 more breast cancers in that dense breasted population. So it can be a great complement. But what are other ones that you're talking about with your patients?
So primarily, we're talking about MRI first and foremost right now. There's certainly a lot of other great screening tests that look very promising and probably are going to play a role. But right now, the one that we are talking about and actually going as far as to recommend to our patients if they're in that greater than 20% risk group is annual MRI.
And are you doing, and then we're doing the same, are you doing an abbreviated sequence at all? Because I know for some women, they're worried about the time that it might take or the claustrophobia, so do you have that abbreviated sequence?
We are not offering an abbreviated sequence right now. It's certainly something that we have been experimenting with in the past couple of years, and I'm sure that we're going to come back to it eventually. But right now, it's not something that we're offering. And we're certainly, and some of it comes down to just, the unfortunate realities of life of, how do you bill for somebody to have an abbreviated MRI and things that just make things that are medical so much more complicated than they need to be. But because that doesn't exist, it actually makes it very hard, just from a practical point of view, to be able to do. But I do think abbreviated MRI is going to come up. We offer contrast mammo. I don't know if the rest of you on this call do. And an ultrasound, of course. We're not doing MBI. Are either one of you doing that?
No, I trained at that with that, but not at this point. And you bring up billing, and I know that's like a boring kind of, not sexy thing to talk about, but unfortunately it plays a part not just in our lives, but in our patients' lives. So you said that you're in St. Louis, Dr. Byers, which is obviously a completely or I assume maybe that it's a completely different payer mix than what Dr. Vinkoff and I might be interacting with. So what's your experience in getting coverage for MRI for your high-risk patients?
Well, I think you bring up a great question. And then to go back to what we're saying about abbreviated breast MRI, we're still doing traditional breast MRI. We have some experimentation with abbreviated. I expect in the next 5 years, we'll be offering that, if solely just to increase availability of the magnet. But we have to have the billing and the ordering come together to be able to achieve that, right? And we don't have those pieces in place yet. The coverage for MRI has been increasing actually pretty substantially over the last few years. So I feel like while we were slow to warm to it initially, it's definitely increased. And our MRI business just in the last 5 years continues to almost double each year. So it's becoming more and more a primary facet of our high risk screening. Similar to you guys, we offer contrast enhanced mammography more as a problem solving tool, less as a high risk screening tool. And then the whole breast ultrasounds. And it's, each patient is different. Some get one combination, some get the other combination. Some it depends on what their insurance will cover. Some it depends on what they're willing to pay for out of pocket. So with each one, we're having to come up with what protocol is going to work with them.
Yeah, I agree. We've seen that same kind of increase, and education has made a huge difference in having our high-risk population asking for these additional modalities. Just the same way that breast density legislation got people to come in and start asking for ultrasound. Now that people are more aware of what their risk is, we have patients now asking to have the supplemental screening, which is great.
Yeah, and two things I like to hit on. So one, the contrast enhanced mammo part. So I, in my first private practice, was in a more rural area, and it was a great option for that patient population for two reasons. One was the payer mix, and so a lot easier to get an insurance company to cover one injection of contrast with a mammogram versus an MRI, and wanting to be able to offer these patients some sort of physiologic test to get that higher sensitivity and specificity was important. And secondly, the breast density in that population overall did tend to be in the scattered or fatty side. And I think we all know that that's when contrast enhanced mammo tends to be most helpful, or at least in my anecdotal experience, that was the case. And secondly, I always like to point out, because patients will ask, well, I want an MRI, or why can't I get an MRI, or my friend gets an MRI. That's not the kind of modality we want to be doing on a population level. Certainly not. I mean, we're already referencing needing more time on magnets just for the people who do need not just their breast MRIs, but maybe their spines and their brains, et cetera. And so it's not accessible, it's not quick, it's not cheap. And there is gadolinium contrast, which, while it is, a predominantly safe agent, there are known risks. And so not as accessible and safe over a population level like mammograms are. So I have that conversation a lot. I don't know if that comes up for you ladies, but
yeah.
I think even just the conversation of why can't I just do an ultrasound? Why do I have to do a mammogram? Just talking about with our patients about what each test shows us, what its strengths are, what its weaknesses are. It's not a one size fits all. Mammography is the best screening tool we have. It is not perfect, but we don't have anything else that can match the sensitivity or specificity at the low cost that we can offer population wide. So that's why we start there. And then talking about as we find things on mammography, how we work them up and why we make those choices. The good news is our patients are educated. They're asking these questions. They want to understand the rationale behind it. And I think that's a great thing. And so I think we owe it to them to explain why we make the choices we make, and as we work through the algorithm of their breast presentation, why we're doing what we're doing.
That leads me to a question for both of you. So you explain all these issues to patients, and what do you do if, even after you've explained why we do things the way we do, they say, I want those tests that don't have the radiation, I want the ultrasound, I want the MRI, I'm not having a mammogram. I know what we do. I can tell you what we do first if you want, but if we've explained to you why we think that mammography is the right place to start, and you still say to us back, I'm not going to have the mammogram, but I will have an ultrasound or an MRI in our place, we're going to let you do that. I'd be interested to hear what the two of you think, because I know this is sort of a controversial topic, but I would rather have people have some screening than no screening.
We do the same. So In my old practice, we might have done it and give it a BI-RADS 0 for incomplete. In my current practice, because this is such a common topic, we do it in document. So, we say the patient has been counseled on, the tagline that mammography, ultrasound is not able to detect calcifications, which may represent early stage cancer. For MRI, I mean, that's a little bit, that they're getting what is in theory the most sensitive test, but that also mammography can in some ways give a global picture in a different way. We do have a lot of patients who, for a variety of reasons, do choose one or the other, though, and just properly document.
Yeah.
Yeah, we're on the same page about documenting. I also just feel like it's important. I want to respect the patient's opinions and feelings. I want them to feel like they're being heard with respect. And I feel like part of it is gaining their trust. And I have had more than one patient who refused mammography for whatever reason initially, and then because of a family or friend experience, came back and said, I think I need to get a mammogram. And they choose to come back to us because you've established that relationship with them.
Exactly. And
so
if you said no to them to begin with, if you drew a line in the sand and you said either you're going to do it our way or the highway, you might have lost that patient, and she might never have come back and had any screening studies at all. So I agree with that approach completely.
Yeah. I see, as we're approaching the 1 or just reached the 1 hour mark, there is one question for Dr. Byers, I think. What software are you using for density assessment, if you feel comfortable discussing vendors?
I do, and I have no financial relationship with any vendor. I will tell you that on a system-wide level, we launched Brca enterprise software back in the fall. We've been slowly bringing on our different institutions, rolling it out at monthly intervals. And pre-COVID, we were set to be live system-wide in March, and now we're actually achieving that in June, both for their density assessment, for their equip review, which is what I'm going to talk about. Just to put a plug in August, we're going to have a discussion about what's been happening since COVID, and I really want to talk about equip and how that's affected our practices. But it assesses our technologist performance. Then it also gives us some very specific markers we can look at to both see which physicians are referring us the highest density of patients, which physicians are referring to us most consistently. It gives you both some demographic, some business type information, as well as a density assessment and an assessment of your technologist. So we're learning it, we're unpacking it as we get more and more experience with it.
Yeah, we are as well. We're putting Volpara goes live for us in July. I have no financial arrangement with Volpara either, but for the same reasons you said, both to be able to have the breast density, but perhaps even more so to be able to have that quality information about the work that we're doing, and to be able to give the kind of feedback to our technologists that are going to make them better and better, as well as being able to satisfy all the governmental regulations that are on us now when it comes to quality.
Government regulations and quality control, a discussion that could go on that is really important. And I always like to turn the tables on that conversation and say, this proves that we're doing what we're supposed to be doing. And this is why, if you do get called back for screening, we're following in certain guidelines, et cetera. But again, another conversation for another evening. I think this has been a really great discussion, though. I really hope that this has been useful for the listeners out there. Do you two have any final or closing thoughts on this topic, or anything that we've
My closing thoughts are just, please, I said this 2 weeks ago, but I'm just going to say it again. Please come in. We hit the pause button, not the stop button when it came to screening. We are clean and safe, and it is so important that you don't skip this year. And when you come in annually, we're able to find your cancers when they're smaller and easier to treat. Annual mammography is what's going to reduce your risk of dying of breast cancer the most. Please don't skip this year because of COVID. Please come in.
Absolutely. Dr. Byers?
I would just add that I'm so excited to see the number of views we're getting with the social media series, and really the international views that we're getting, because we're all in this together. I don't say that to be sophomoric. I really believe that we're all in this situation together. I know all of us, you can follow any of us and all of us on social media, but I really encourage you to follow Society of Breast Imaging on Facebook, Twitter, and Instagram. You can reach out to us with questions. We are happy to answer them. We're just so excited to have people interested in these conversations. And if there's something we can answer, please let us know.
Absolutely. So I echo the two of you. You know, they're projecting 80,000 breast cancers could be missed due to COVID. The system is going to take a really long time to catch up to those months that were, for the right reasons, paused. But now we're back at it. We know how to do this safely. We're sanitizing, we're distancing. We have the PPE, thankfully, that we need. But, you know, in order for mammography to do what it needs to do for that early detection, we need to be getting those women in. So yeah, thank you for being a part of this. You can find us online. You can find me at Anjali Malik, MD, at Nina Vinkoff, MD, I believe. Is that correct? And Dr. Byers, you want to share your handle as well?
I think I'm at Meredith S. Byers, MD. And I just want to send a big thank you out to Dr. Malik. This was an excellent conversation. Really, we appreciate the opportunity to do this with you.
Thank you so much. Any questions, definitely send them our way, and we look forward.
Oh, and I'm moderating next week. So I'll be back next week. We're going to be talking about the changes that have been made in breast imaging practices in response to COVID.
Awesome, which that's a perfect segue to next week. So we'll see you then, 6 p.m. Eastern Standard Time.
Thank you so much.
Thanks.
Thanks, everyone.
Bye.